Hello everyone. I will give a brief overview of the medical management of chronic pulmonary aspergillosis, as well as the important issues like prognosis and the frequency of relapse of this disease. The mainstay of therapy is the oral triazole agents, and they have been shown in clinical trials to improve symptoms and the quality of life. But usually the treatment is long-term because of the risk of relapse. And all of the mold-active azoles have been used in clinical trials and have been shown to be beneficial, with the exception of Itraconazole, for which we don't have any data yet. The intravenous antifungals like amphotericin B or the echinocandins also have a role to play, especially when oral treatment is not possible for various reasons. And these patients, let's not forget, they are usually chronic respiratory patients who may develop secondary infections like bacterial infection with Pseudomonas or non-tuberculous mycobacterial disease. So they may want close follow-up for for bacterial antibiotic treatment, and usually immunization is recommended, like the yearly influenza vaccination or pneumococcal vaccination. Some patients who are on immunosuppressive agents like steroids in case of sarcoidosis or chronic obstructive pulmonary disease may benefit from having the immunosuppressive therapy reduced, as this might improve outcomes. And finally, there have been some case series of interferon gamma supplementation being beneficial for some patients, as it can potentially control the infection progression. So the clinical spectrum of CPA is quite broad. At the one end of the spectrum, we have the simple aspergilloma, which is essentially a single fungus ball in a well-circumscribed cavity, which may cause no symptoms, in which case you just monitor the patient without any treatment. But importantly, it can result in even massive hemoptysis and life-threatening hemoptysis, in which case the treatment option would be surgical resection, which is also curative in this situation, as antifungal medications usually do not work very well in this setting. There is the other important entity of the Aspergillus nodule, which usually is challenging, as it may initially look like lung cancer, and this patient may have surgery to remove that, or a CT-guided biopsy, only to find hyphae in the tissue or a positive Aspergillus culture. And again, these patients can be followed just like any patient with a nodule would be followed, with serial imaging. But if the nodule enlarges, they could benefit from antifungal therapy, or if there are multiple nodules. And finally, the most common clinical picture is that of chronic cavitary aspergillosis. Sometimes these patients present with bilateral disease, very extensive bilateral cavities with aspergillomas, and also with extensive fibrosis occasionally. These are the patients who present with severe symptoms like systemic symptoms like weight loss or malaise, anorexia, and also respiratory symptoms, and including hemoptysis. And they typically might benefit from a course of oral antifungal agents like Itraconazole or voriconazole, and the treatment is continued usually beyond 6 months because of the risk of relapse. And I will show you in a minute the main challenges when monitoring patients on long-term antifungals. Some patients may present very acutely unwell. They may end up in the hospital, so they might benefit from intravenous antifungals like amphotericin B, intravenous voriconazole, or intravenous echinocandins until they're more stable, and then switch to orals. The majority of patients are not that ill to require admission, but they present chronically unwell and they're seen in the clinic. And these are the patients who can benefit from oral azole treatment. And finally, some patients who present with few or minimal symptoms who can be monitored, but you have to be careful also about progression of the disease in patients who are asymptomatic. So even an asymptomatic patients might need serial imaging of their chest to look for progression of disease. So the aim of treatment is mainly to improve quality of life by minimizing symptoms, and one of the important symptoms is hemoptysis, which can be life-threatening, and the role of oral antifungals also could be to reduce hemoptysis, and also to try to stop the progression or sometimes reverse the progression of the destruction of the lung tissue. The main challenges are the emergence of antifungal resistance and also the toxicity of those agents, as I will describe in a minute. So our preference is to start with either Itraconazole or voriconazole, as obviously these agents have been there for longer and there is more experience in their use. But obviously posaconazole and isavuconazole are the newer agents, which should work as well, and they may be reserved as second-line agents in case of failure of treatment or in case of side effects to the other agents. The main and most feared consequence of treatment is development of resistance. This typically can happen in a patient with a significant burden of disease, like presence of multiple aspergillomas. Aspergilloma is a very good medium for development of resistance, unfortunately. Adverse events are quite common in large number of patients. There is a class effect of all of those agents, which is to cause liver function test abnormalities. But itraconazole can also characteristically cause heart failure, and voriconazole can cause a very bothersome and very severe sometimes photosensitivity reaction, and there have been cases also of skin cancer developing on voriconazole, especially if somebody has been on long-term treatment. Drug interactions is also something that every doctor prescribing antifungals should be aware of. A typical example is rifampicin, which is used in the case of tuberculosis or non-tuberculous mycobacterial disease, and essentially you cannot use rifampicin with any of the azoles, as it results in undetectable levels of all of the azoles. Another example is the use of omeprazole with itraconazole capsules, which results in reducing the absorption of itraconazole. And yet another common example is the interaction between lipid-lowering medications and the azoles, which can result in rhabdomyolysis as a side effect. And these are only some of the most common interactions that we encounter. The response to treatment is difficult to assess in those patients. These are patients who also have secondary comorbidities like chronic obstructive lung disease or sarcoidosis, and they also could get secondary bacterial infections. So it is very difficult to assess the response to therapy, as it can be confounded by other conditions. But in most case series, the response to antifungal therapy has been around 60 or 70%, as assessed by different ways. And this is also true for the intravenous antifungals, which you generally tend to give for a briefer course, as it is not practical to continue long-term intravenous antifungals usually. And this is the only randomized placebo-controlled trial of itraconazole in CPA. This is a trial from India, in which patients were randomized to 6 months of itraconazole. And as you see here, these patients had a significant response. A large number of patients had a significant response compared to placebo. But then stopping the treatment at 6 months, a large number of those patients will deteriorate at 12 months. So it's estimated about 30% of patients might have a relapse when you stop the treatment at 6 months. Therefore, more prolonged treatment may be the way to go in some cases. Intravenous antifungals, we tend to use those for patients who cannot tolerate oral antifungals, or patients who develop resistance to oral antifungals, or clinical failure. We tend to administer a short course between 2 to 4 weeks. The intravenous treatment can be used initially in patients who present very unwell, acutely unwell with severe disease, before stepping down to orals. And actually the symptomatic benefit may persist for weeks or months after completing the course. So one way to go would be for patients who have no oral antifungal options to give 3 to 4 courses per year, and this could maintain remission in those patients. As you see, these patients are followed for several years. This is a series from our center, and as you see, the mortality can be quite significant. Again, it is affected by various factors, and I will show you a study that showed that tried to identify risk factors for poor outcomes in those patients. Relapse is a common problem, as I showed before. Again, it is difficult to exactly diagnose a relapse in those patients. In the majority of patients, they will have deteriorating clinical symptoms, but this, as I said, could be caused by other conditions like secondary bacterial infection or progression of their COPD. The most unequivocal way to diagnose a relapse is with radiological means, with a CT scan of the chest, where you might see an enlarging aspergilloma or the presence of new cavities or increasing thickness of the wall of a cavity. We use serological markers like Aspergillus IgG titer, which can go up in the case of relapse, but there is no very robust data that this really associated with poor prognosis. And finally, you can get a positive microbiology. Fungal culture should be sent, but as you know, the sensitivity of fungal culture is moderate at best. The approach in our lab, the mycology reference lab, is to do an Aspergillus PCR, and if positive, if we have a negative culture, then we can proceed with a high volume culture, which has been shown that may have a better sensitivity compared to the traditional culture. Various case series have shown a recurrence rate of about 10 to 40%, and importantly, even after surgical excision of an aspergilloma, relapse rate could be significant, as you see, but usually patients with simple aspergillomas tend to do better in terms of post-surgical relapse. There was one study from Japan that specifically looked at the risk factors for relapse of disease, and those were found to be younger age, and probably the most important one is the extent of disease. So multilobar or bilateral disease is associated with a higher rate of relapse. So in those patients, potentially you might want to treat for longer. And finally, patients who required antifungal treatment for a longer period in order to induce remission were also at a higher risk of relapses. This is the study from our center. It is a large retrospective study of several hundreds of patients that were seen over several years that tried to identify the risk factors for mortality. A very important one is low body weight. So patients presenting with cachexia, severe weight loss, actually the prognosis might be poor. Patients having non-tuberculous mycobacterial co-infection also tend to do worse. This is because they need to be on dual treatment for both infections, and there are drug interactions and drug toxicity in that case. This is a typical example of the rifampicin interaction with the azoles. Underlying chronic obstructive pulmonary disease, of course, the severity of that clearly affects the mortality, as patients with end-stage COPD may actually die from COPD rather than from the chronic aspergillosis. Higher age and lower albumin, for obvious reasons, are also associated with a poor prognosis. And finally, we can assess the quality of life by using questionnaires like the St. George's Quality of Life questionnaire, which we do regularly in our patients. And actually, worse score, as detected by the St. George's Quality of Life questionnaire, can lead to also to worse prognosis. And also, again, probably self-explanatory that bilateral disease tends to have a worse prognosis than unilateral disease. So in summary, the long-term oral triazole therapy is the mainstay of treatment for those patients, but usually you need to continue for a prolonged period, usually at least 6 months, but probably in some cases very prolonged treatment. The associated problems there are, of course, the development of side effects, the drug interactions, and the cost of treatment, and finally the development of resistance, in which case the intravenous agents could be used, as they can be used to maintain remission if given over several weeks of treatment. Unfortunately, stopping the treatment, the patients have to be followed quite closely for several years sometimes, as the risk of relapse is quite common, and patients should be monitored both clinically and potentially with further tests or imaging. Thank you.